Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello, everyone. Welcome back to Cardiovascular Matters. I'm here with Dr. Craig Walker, and I'm Terry Roberts, and we're going to be talking today about a very interesting technique that involves a device, but we really want to talk more about the technique today. Dr. Walker it's made a profound statement and has a huge footprint, no pun intended, in peripheral vascular disease. We want to talk about this new technique that accompanies when you're doing a procedure in the legs, and a way that you can prevent embolization to occur, which wasn't highly recognized or even appreciated in the past because you couldn't see it on angiogram. And Dr. Walker will get into the details of that. I'm probably butchering this, but I want to make sure we kind of lay out the premise of our talk today. And this is just something to me. It's so fascinating because I was a rep in the space for 20 years, and I've seen tens of thousands, if not 20 or 30,000 cases. But we just didn't have this technology, and I think it's what I like so much about it is it's simple, and it's so effective. I mean, it does what it's supposed to do. So, Dr. Walker, could you share some information about this and the studies that have already been published about it?
Sure, Terry. So, as you well know, I've been involved with trying to improve peripheral vascular interventions from the beginning and have been a lead investigator for many
Right.
things. Original stents, which would hold vessels open, atherectomy to help remove plaque, modification of balloons to make them more effective, drug-eluting balloons to try to, and drug-eluting stents, once again, to improve outcomes. But one area we've never really concentrated on, in my opinion, as much as we should, is the risk of material within long totally blocked
Right.
vessels breaking off and going downstream down the vessel as we open the vessel. Now, historically, we knew when people would put Doppler probes on the outside of the vessel, there were what we call hits or signals that some debris was going downstream. However, in general, we dismissed it if we could not see it angiographically as maybe being clinically insignificant. Now, it's very important to understand an angiogram may not show everything that's happening in a vessel. It's the best we have right now, but it may not show things. So I was intrigued. I'm the editor of Vascular Disease Management. And in the March edition, Tom Davis and colleagues had submitted an article that really captured my attention. And in this article, what they did was a process called total occlusion embolectomy. And they would use a blood pressure cuff placed beyond the area that we were trying to treat. And they would blow this blood pressure cuff up to a little bit higher pressure than the pressure in the artery, about 20 millimeters of mercury higher than the pressure in the artery. They would then perform the procedure, be it an atherectomy, be it a stent or a balloon, and they would do the procedure. And then following doing the initial planned procedure, they would go in with a device. The device is called a Roval device, but that's not really what I want to
Right.
speak of. I want to speak about the
Right.
concept. We're going with this device which spins and sucks out potentially debris. And they found that in 104 consecutive cases of long occlusions, they retrieved debris that was visible debris that's big enough to where when you take it out, you see it with your
Right.
naked eye. And sometimes that debris was actually quite big and made of hard stuff. Now, that really opened my eyes because I said, I've been blinding myself for many years to this. Basically, we didn't have a concept of how to deal with this. Historically, people had tried to some degree with distal wire
Right, right.
protection, using distal protection devices, but these are not made for long occlusions because the basket on these is not big enough to catch all the debris. Uh, a lot of debris
Right.
escapes, and these devices often move in procedures and can injure the
Well,
arteries
and you couldn't get
themselves.
them past those
So we
long
really did.
occlusions.
Yeah,
Yeah,
sometimes you could,
tough.
and
Yeah,
certainly sometimes they
right,
would move and potentially injure the vessel or miss catching debris. So they retrieved in 104 consecutive cases, 98% of people, they retrieved visible
right.
debris. Now, I can promise you if there was visible debris, there was invisible debris, which is also important because a red blood cell is very invisible to us. A single red blood cell, when we have a lot of blood, we see it, but a single red blood cell is beyond our ability of vision to see. And so there can be debris that could choke up our capillary bed as well. But visible debris can block other vessels. And it's probably part of what sometimes is seen with the slow flow phenomenon right at first following an intervention. So they utilized this and retrieved debris. I, of course, was curious about this. I called and I, uh, I tried the technique that Dr. Davis had set forward, and I used it in 10 consecutive cases. And the cases I get are often the worst of
Right.
the worst. They're people that many physicians have failed on first and refer them to me. And in 10 out of 10, I retrieved debris and a fair amount of debris, like not a little bit, quite a bit of debris, to which I'm really optimistic that this may prove to be one of the missing elements for us achieving better outcomes in peripheral intervention. So, when we're treating coronary artery blockages, we're typically treating a blockage that's really very
Right.
short. Often these are just a few millimeters in length, and usually they're not totally blocked. Usually they're just what we call stenotic.
Right.
They're not totally blocked. Sometimes they're totally blocked, and sometimes on a really unusual case, we may have as much as 6 centimeters or roughly 2.5 inches of blockage. But again, that's nothing compared to 40 centimeters of a totally blocked leg artery, which is much bigger in size and diameter as well. So you can imagine the volume of debris that would occur in a very
Right.
long blockage, one that would go from the hip to the knee in a vessel as big as your little finger. You could send an awful lot of debris downstream. Now, despite these vessels being bigger, historically, the likelihood of a blockage coming back, which we call restenosis, the likelihood of that blockage coming back was much higher in the peripheral space than it was in the coronary space. We attributed that to many things. The flow in coronaries, even at rest, is much
Right.
faster than the flow in the legs. Um, but keep in mind, the vessels are much smaller. Historically, a really big coronary is less likely to develop restenosis than a small coronary. So these leg vessels are bigger than any coronary vessel would be, and yet restenosis was high. Now, granted, these were much longer blockages, and we know longer blockages are more likely to come back than shorter blockages. But is maybe one of the elements, a really crucial element, the fact that maybe we're sending debris downstream historically by when we don't protect against this. Now, there have been some surgical reports in the past that state that if they do a bypass after a failed intervention, that the patency of the bypass is not as good as in other patients. Now, that's a two-edged sword because often if bypass is done first and we do intervention, once again, and the bypass fails, oftentimes the intervention doesn't work as well. But is maybe part of the puzzle there that with these first interventions, we've missed sending debris downstream, which might affect flow. And as we affect flow, might really hinder our ability to have a vessel that stays open long term. I'm a big believer that we have to do a better job in peripheral interventions. And we have really devoted a lot of our life to improving these because when one has a leg with blocked arteries, that sick leg is never attached to a healthy person. And what often kills these people, or heart attack, or stroke, or other issues such as that. But I don't think there's anyone that I've ever met that said, "Well, I would really like an amputation. I'd really like to have to hobble around for the rest of my life," particularly if you're an older person and it's hard to recover from that amputation. And so we've been looking at ways to solve that, and we have improved dramatically. Historically, people presenting with critical limb ischemia, and that's defined as true ischemic breast pain, non-healing ulcers, or gangrene. Uh, that was really kind of a death sentence because many of those were sent straight to major amputation. And now, with some of the newer interventional techniques and some surgical techniques, we believe that about 90% of those cases can avoid major amputation, maybe more. But could we even improve that further by dealing with this whole issue of debris? And I'm firmly of the opinion with what I have seen and what I've experienced now in 43 years of being one of the busiest peripheral interventional doctors in the world. I'm convinced that this has some role. Is it the major role? I don't know. But I'm convinced it has some role. And I will tell you something that I saw in the past when we did put distal protections devices down, we did often retrieve some debris. And that was despite the limitations of distal protection devices which move. And sometimes in cases, the basket was not big enough to capture all the debris. Debris was flowing over. And in some cases where there are calcific nodules that were knocked off, the basket could not be retrieved by normal function. It couldn't squeeze it down inside the capture tool. And so I think there's a lot to think about with this article. And like every now and then I see a publication or I'm involved in a new technique or procedure that I think, oh, this is going to really make a difference. I felt that way in a big way when we first got stents. Stents to me were magical in terms of, particularly in the heart, where before when we would just do a balloon angioplasty, we'd be worried all night long, might that vessel suddenly slam shut? Well, stents came along and just changed that dramatically. Then medicated stents, once again, what a difference they made. Uh, really now, a medicated stent placed properly and sized properly and dilated properly has a better patency rate than vein bypass grafts of the heart. So it's not only as good, it's better. It's not better yet than an arterial bypass, but better than a venous bypass in the heart. And most bypasses done are venous, with perhaps one artery used for one vessel. But I think that those were epiphany moments to me in my career when I said, "Aha, this is going to make a difference." And as I read this article and subsequently looked at this, I thought this was really another epiphany moment. So as I'm training young doctors, fellows, and other people in the field, I'm very clear telling them, look, if you believe your training is over now, you're in the wrong profession. Uh, Medicine is a lifetime of learning. It is really a vocation. It is not just a practice of medicine. It's a vocation. It's a vocation to your patients, but it's also a vocation to making sure you're going to do the latest and the best for them. Not all changes are better, but many changes. The only way we do get better is via some change. And the only way one can do that is by learning all the new techniques and new things that come out. So, we have progressed so much since this field began. Better ability to cross blockages, better ability to diagnose them, better ability to treat the patient after, with medicines that can lessen recurrent events. uh, better tools like stents and things that can block elastic recall, shockwave balloons to also, once again, deal with calcium. And now, perhaps adding to all of that, our ability to lessen any debris going downstream, I think, might really be a key to improving outcomes further.
Interesting. Well, the comment you made about, it's a lifetime of learning and evolving. I really love the fact that you stay so current, uh, with what's going on in your field. I think, not every physician is doing that. You know, they may not evolve, and, they're doing it the way that, they were taught, coming through their fellowship, and, haven't wanted to take on any new, changes. But, I totally agree with you, because things do improve and get better, and that offers your patient a better outcome. And being able to retrieve and remove this material that's in the vein, that or in the artery, I should say, I'm sorry, in the artery, as you repair that artery and open it up, I think is very important, because if you're not allowing that to go downstream somewhere where we once thought it was insignificant or it would metabolize or whatever, um, that's often not the case. So, this, I think, will have a profound effect on restenosis for these patients, so they can come in and get a good result, that's long lasting and effective. And, once again, Dr. Walker, I really appreciate you sharing your insight on this. This was all new information for me, but I think it's, having been in the space and participated in so many of these cases, I can certainly see how effective this is and how meaningful it is. And the thing I like most about it is that it's a very, relatively, compared to other devices and technique, it's simple. And, I love that, because, I've seen so many devices, it's like, stand on your head, scratch your ear, press this button, press that button, now twist it, now, I mean, it was just unbelievable. And it makes it difficult, because if you're not doing it every single day, every moment, it's like, every time you're out doing it, it's the first time. So I see this as such an absolute repeatable, safe and effective way to treat this problem that exists in these procedures. So, I want to thank everybody for checking in to this episode of Cardiovascular Matters. Uh, I'm Terry Roberts here for Dr. Craig Walker. Thanks for listening, and be sure and like and follow us, and turn on those subscribe to this. That way you'll notice when we have new episodes drop. Thank you very much.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.